Hi, everybody. It's about 1 minute past the hour, so I think we'll get started. Some people are still dialing in, but we'll just begin with our introductions. So good afternoon and good evening. My name is Sarah DeFeo. I'm the Vice President of Scientific Affairs and Programs here at Ovarian Cancer Research Fund Alliance. And I want to thank you all for joining us today as we continue our webinar series for 2017 with today's presentation on rare ovarian cancers. OCRFA's webinar series has been supported by Genentech, so a big thank you to Genentech for making this webinar and all of our webinars possible. So just a little bit about our organization. OCRFA is the largest global organization dedicated to fighting ovarian cancer. We advance research to prevent, treat, and defeat ovarian cancer. We support women and their families before, during, and beyond diagnosis, and we work with all levels of government to ensure ovarian cancer is a priority. So before we get started, I have just a few housekeeping sort of notes to go through. All of our listeners will be in a listen-only mode throughout the presentation. We should have some time for questions after Dr. Gershenson is done speaking. So if you think of a question as you're listening, please type it into the Q&A box that you can see on the right-hand side of your screen. I'll see the questions and I'll select some to ask at the end of the presentation. And there's no need to wait until the presentation is over to submit the questions. You can just type them in as we go along and as you think of them. That's absolutely fine. So I'm really thrilled that Dr. David Gershenson is joining us this evening. I think looks like some people on the phone know him well. I think we've got some current and former patients on the phone, it looks like, based on what I saw of the registrations. Dr. Gershenson has a long and distinguished bio. I could spend a long time going through it, but I'll hit just a few highlights. He is professor in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center, where he served as chair of that department from 1998 to 2012. His major focus is on clinical and translational research of rare ovarian cancers. Since 2005, he served as the chair of the NRG Oncology's Rare Tumor Committee. He served as co-chair of the NCI's Gynecologic Cancer Steering Committee and was editor-in-chief of the journal Gynecologic Oncology for many years, and he currently serves on the editorial board of the Journal of Clinical Oncology. He's also a member of the National Comprehensive Cancer Network Ovarian Cancer Panel and served as chairman of the Foundation for Women's Cancer from 2009 to 2015. So he's a real leader in the field, an expert on this topic, and someone who gives very generously of his time to the community that he serves. And so I'm very grateful that he's here with us today. So yeah, without further ado, let's get things started. Dr. Gershenson, I will pass the mic to you, and you can get started.
Great. Thank you, Sarah. Well, let me personally welcome all of you to this webinar this afternoon, this evening. It's a real pleasure to be with you and hopefully provide a brief overview of rare ovarian cancers. And as Sarah mentioned, we'll plan to leave, I hope, about 20 minutes at the end for questions. So I'm going to talk about rare ovarian cancers, the areas where we've made progress, and some areas where it's been a little more challenging as we go through this. So these are some of the challenges and barriers to the study of rare ovarian cancers, and these are all pretty intuitive. You know, we deal with a small number of cases in almost all of these cancers. Therefore, if we try to conduct clinical trials, we have long accrual times, which can be a problem. There aren't that many investigators that have been interested in rare ovarian cancers or rare tumors in general. And there's less attention by not only the scientific community, but also the pharmaceutical community, so that funding priorities are low and so on. So there are a number of challenges that are associated with the study of these tumors. So today I'm going to talk about three broad categories: rare epithelial tumors, so that'll be mucinous clear cell and low-grade serous, sex cord stromal tumors, and then we'll end with germ cell tumors. And with each topic, I'm going to try to discuss a little bit about the basic features, the standard treatment, and some of the ongoing research in the area. So we'll start out with the rare epithelial tumors. Of course, the referent type is the most common high-grade serous, which we will not discuss today, but that's the type with which all of these are commonly compared. So we'll start out with talking about the new paradigm that's occurred within, I think, the last decade or so, where we've really fully recognized that ovarian cancer is not one but several distinct entities, and in fact, one size does not fit all. There have been advances in the pathologic diagnostic criteria for these tumors, as well as clinical studies that have provided insights. But I think the most advances have been made in the area of molecular biology and genetics in the study of these tumors. Prior to about 2005, all epithelial ovarian cancers were treated identically, and there really were no prospective clinical trials for the rare subtypes. In 2005, the Gynecologic Oncology Group established the Rare Tumor Committee, and at that point, we began to develop separate clinical trials for specific subtypes. So a little bit about the basic features of these three subtypes. They all account for about 5% of all ovarian cancers, so they're rare. The stage distribution is very similar for clear cell and mucinous, but very different for low-grade serous. So in clear cell and mucinous, predominantly these tumors are early stage 1 and 2, whereas in low-grade serous, it mimics high-grade serous cancer, and most of the tumors are advanced stage. Likewise, the biology is very similar for mucinous and clear cell, that they tend to be somewhat aggressive, whereas low-grade serous carcinoma tends to be more indolent. However, all three of these subtypes share the feature of being relatively chemoresistant to conventional treatments. And I underscore the term relative because they're not completely chemoresistant. And then in the last two rows there, you see the outcomes. So in early stage disease, mucinous and clear cell are very similar to high-grade serous, whereas low-grade serous, which is very uncommon in the early stages, has a better prognosis. And then in the advanced stages, clear cell and mucinous are somewhat worse than high-grade serous, and low-grade serous carcinoma has a much better prognosis. A little bit about the standard therapy for all three of these, it's very similar. So in apparent early stage disease, surgical staging is performed with the removal of the involved ovary. Of course, in older patients, abdominal hysterectomy and bilateral salpingo-oophorectomy is performed, but in younger patients, fertility-sparing surgery is certainly possible in a subset of those patients. If the tumor appears to be confined to the ovary, then usually these, certainly in mucinous and low-grade serous carcinoma, surgery alone is the treatment. There's no postoperative therapy. In clear cell carcinoma stage 1A, confined to the ovary, I think most physicians will recommend platinum taxane chemotherapy, although that is a little bit controversial. And then for patients who have stage 1C and 2 disease in the early stages, combination chemotherapy is the recommendation. And then in advanced stage disease, as you know, the major principle is maximum cytoreductive surgery, hopefully to no gross residual disease. And then the options at that point would be chemotherapy. If patients have very extensive disease initially, it may be recommended that they have neoadjuvant chemotherapy prior to undergoing interval debulking surgery. And in terms of the options for chemotherapy, you know, paclitaxel carboplatin is the standard, but there are several variations on that theme, including intraperitoneal chemotherapy, dose-dense paclitaxel chemotherapy, and the addition of bevacizumab or Avastin, including maintenance therapy. So a little bit about these three subtypes. So mucinous carcinoma probably is the most challenging because, as we found out in the last 5 years or so, it's much less common than we even thought. We know that it's relatively not very responsive to platinum taxane chemotherapy, and the clues that we have is that it may behave like colorectal cancer in that it may respond somewhat better to chemotherapy regimens that have been used for colorectal cancer. And we've also learned a little bit about the molecular biology of the disease. So we think we know that the angiogenesis pathway may be a potential target. So Avastin or bevacizumab, based mainly on the experience with colorectal cancer, seems to be an appealing target. As in breast cancer, the HER2 new gene will be amplified in about 20% of mucinous carcinomas of the ovary, and a KRAS mutation may occur in 40 to 50%. So these are potential targets for targeted therapy. And then the SRC gene has been found to be a potential target as well. So this was a clinical trial that was developed really with our colleagues in the United Kingdom. It's a randomized phase 3 study that was begun a few years ago for mainly patients with metastatic mucinous carcinoma of the ovary. Over 300 patients were planned to be accrued to this trial, and patients were randomized to either the standard chemotherapy with carboplatin paclitaxel or to a colorectal cancer regimen of oxaliplatin and capecitabine, and then there was a secondary randomization in each one of the arms to Avastin or no Avastin. Unfortunately, this trial was closed prematurely because we could not accrue rapidly enough, and so that was really a tremendous disappointment, and we really did not learn very much from that trial. So that's why I say the study of this tumor is very challenging. While we were conducting the trial, we actually found out, based on this retrospective study of patients from a GOG trial, that actually mucinous carcinoma was much less common than we had thought, and then in fact about 70% of tumors that had been diagnosed as mucinous carcinoma of the ovary actually were gastrointestinal primary cancers. So that explained, I think, somewhat the rationale for not being able to complete this trial. So I think that has been a disappointment, and we need to determine how to move forward with this subtype. Clear cell carcinoma has been much easier to study. We know that, as you know, endometriosis is a benign condition that afflicts thousands of women associated with pelvic pain, with infertility. We know that about 1% of all women who have endometriosis may have the development of an invasive cancer within the endometriosis. And this study just really showed that clear cell carcinoma would be the most common type that develops in endometriosis. We know we've learned a lot in the last decade about the molecular biology of clear cell cancer. About 50% of these tumors have a mutation in the ARID1A gene, which is a tumor suppressor gene. About 30 to 40% of these tumors have a mutation in the PI3 kinase AKT-mTOR pathway, and then there are a number of other genes that may have aberrations as well. We also know that the VEGF gene is a promising therapeutic target because VEGF is strongly expressed in both early and late stage clear cell carcinoma. Of course, this is a target for bevacizumab or Avastin, so that is yet another target. And so you see in red there the pretty common potential targets, the ARID1A gene, the PI3 kinase pathway, angiogenesis. And then there's considerable interest now in immunotherapy for clear cell carcinoma based on some early results. So the PD-1 and PD-L1 are expressed in clear cell carcinoma, and microsatellite instability is not uncommon as well. And then you can see there are other genes or pathways that may be relevant but haven't been explored as well as some of these others. This is a table of the clinical trials that have been performed in clear cell carcinoma. The Japanese trial and the second trial are frontline trials. The Japanese trial used irinotecan cisplatin versus the standard chemotherapy in a very large number of patients, and there was really no significant difference in the outcomes for the women in that trial. GOG conducted GOG 268, combining an mTOR inhibitor, temsirolimus, with standard chemotherapy, and then giving the temsirolimus as maintenance therapy as first line. That study has been completed in 90 women, and then the results really don't look any better than historical controls. So that was essentially a negative study. And then there are studies in recurrent clear cell carcinoma. Sunitinib, GOG 254, was studied in women with recurrent clear cell carcinoma with only a 7% response rate. Cabozantinib, which targets the MET gene, was studied in a phase 2 trial, and that also actually closed after the first stage, so it was a negative study as well. And then there was a study with ENMD, which is a multi-tyrosine kinase inhibitor, which had only a 2% response rate. So all three trials were essentially negative. Dasatinib is a trial that's been completed, and the results are pending. And then there's a trial in Scotland with another anti-angiogenesis drug that is still recruiting. And then finally, a trial that the NRG Oncology is currently developing with an immune checkpoint inhibitor, pembrolizumab, with an IDO inhibitor. This is a CT scan of a patient from one of the reported studies in 2015 treated with an immune checkpoint inhibitor. This patient had a complete response to therapy and was doing well at a year. And so there's tremendous interest in immune checkpoint inhibitors in clear cell carcinoma, and I think that's the greatest hope right now and the greatest concentration. And then low-grade serous carcinoma. We have also learned a lot about the molecular biology of this tumor. We know that KRAS can be mutated in about 20 to 40% of these tumors, BRAF in about 5%, and then there are other mutations, NRAS, et cetera, et cetera. And so while KRAS and BRAF may be targets, we also know that over 80% of low-grade serous carcinomas have expression of the estrogen receptor, which is yet another target. We also believe the angiogenesis pathway is a target based on experience that I'll mention in a moment. The insulin growth factor receptor 1 is a potential target because the expression in low-grade serous carcinoma seems to be robust. And possibly the PI3 kinase pathway is a target as well. In 2004, the grading system for low-grade serous carcinoma, or for serous carcinoma, I should say, changed dramatically from a 3-tier system to a binary system, and I think that really helped move the field forward. We know that low-grade serous carcinoma may occur de novo, or it may occur following a diagnosis of advanced stage borderline tumor of the ovary. As you know, multiple studies, mainly retrospective studies, have been reported that show relative chemoresistance of low-grade serous carcinoma, so there's great interest in finding alternative therapies. And this is a study from the AGO, which is a German cooperative group, in which they reviewed over 5,000 patients, and they were able to identify 145 patients with low-grade serous carcinoma. And of the 39 patients who had suboptimal debulking or measurable disease, the response rate to chemotherapy was only 23%, where in a similar group of high-grade serous carcinoma patients, the response rate was 90%. So again, it just highlights the relative chemoresistance of low-grade serous carcinoma. So there are three areas, I think, of concentration of treatment for low-grade serous carcinoma. One of them is anti-angiogenic therapy. There have been 3 studies reported using bevacizumab or Avastin in low-grade serous carcinoma. The middle study there is a little bit unusual because it includes patients who received bevacizumab as first-line therapy. But if you look at the first and third studies, you see that the response rates are in the 40 to 50% range. And, of course, many of these patients received bevacizumab in combination with chemotherapy, but a number of them also received single-agent bevacizumab. So there's no question that this is active therapy in this disease, and I think needs to be investigated further. A second area is targeted therapy. So a phase 2 study of selumetinib, which is a MEK inhibitor in the MAP kinase pathway, was performed by the Gynecologic Oncology Group. The response rate was 15%, and another 65% of women had stable disease for varying periods of time. Disappointingly, there was no correlation, however, between response and whether or not the tumor included or contained a KRAS or a BRAF mutation. So this is a patient who was treated in that initial study of a MEK inhibitor, and as you can see, in a 4-month period, she had a very nice partial response to this treatment. BRAF inhibitors have also been reported in case series, and this is a CT scan of a patient who had therapy, had a BRAF mutation in her tumor, underwent BRAF inhibitor therapy, and had a very nice partial response to this treatment for a period of over a year. There are now a number of second-generation trials with MEK inhibitors. This is the MILO trial. This trial has been completed. It was closed somewhat prematurely because of futility, and the results have not yet been reported. But it was a randomization between the MEK inhibitor MEK162 versus standard chemotherapy in women who had recurrent low-grade serous carcinoma. And I expect that this trial will be reported out in the next year or so. GOG 281 is still ongoing, although it's been closed in the U.S. and it's still open in the United Kingdom. Very similar design. Women with recurrent low-grade serous carcinoma randomized between trametinib, the MEK inhibitor, versus standard chemotherapy, or in this trial also potentially hormonal therapies. There is a considerable interest in combining targeted agents, and this is a trial that combined a MEK inhibitor with a PI3 kinase inhibitor and compared it to a MEK inhibitor alone. Unfortunately, the toxicity was too great in this trial, so it was closed prematurely. And again, the results have not yet been reported. About a month ago, we activated this trial at MD Anderson, which is based on preclinical work showing that a MEK inhibitor combined with a PARP inhibitor, and as you know, PARP inhibitors are mainly effective in women who have a BRCA mutation or in women who may just have high-grade serous carcinoma even without a BRCA mutation. Really hasn't been studied, though, in low-grade serous carcinoma. So we're combining a MEK inhibitor with a PARP inhibitor in women who have low-grade serous carcinoma with a KRAS mutation. And, of course, this trial also includes other tumor types. We also know that low-grade serous carcinoma has a lot of similarities with ER-positive breast cancer. At least, as I mentioned, 80% of these tumors express the estrogen receptor. Like breast cancer, we know that women who are younger have a somewhat worse prognosis. We also have found that, in fact, hormonal therapies can have activity in recurrent low-grade serous carcinoma, and also as maintenance therapy following primary chemotherapy. So we have in development about 3 trials with hormonal therapy. This is a trial that hopefully will be activated before the end of 2017. It's for women who present with newly diagnosed extensive low-grade serous carcinoma and who would have been treated previously with neoadjuvant chemotherapy. This trial will be using neoadjuvant hormonal therapy with fulvestrant combined with the CDK4/6 inhibitor, which is thought to enhance the activity of the hormonal therapy and actually is a treatment that's FDA approved for ER-positive breast cancer. So this trial is a pilot study of 15 patients that will open in the not-too-distant future. A second trial is for women who have recurrent low-grade serous carcinoma, and again, it's using the principle of combining a hormonal therapy with a CDK4/6 inhibitor. This trial probably will open the second quarter, we hope, second quarter of 2018. And then we're also planning to develop a trial in first-line treatment of women with low-grade serous carcinoma with stage 2, 3, or 4. This is based on retrospective information from our institution where we found that women who had primary surgery followed by platinum taxane chemotherapy, if they were then given hormonal maintenance therapy for an indefinite period, had a better outcome than women who just went on observation after they completed primary chemotherapy. And there also was a study from Johns Hopkins in which 27 women underwent primary surgery and received no chemotherapy postoperatively but were given hormone therapy instead. And again, their outcome was very provocative and promising. So that has allowed us to develop this trial, which is a randomized trial for women who will undergo primary surgery, and then they will be randomized to either standard chemotherapy or hormonal therapy. And then there's a secondary randomization for the women who have chemotherapy to either observation or to hormonal maintenance therapy. So it's a 3-arm study, really, and would include 350 patients. And we hope to have this study approved in the near future and open sometime in 2018. We'll move on now to ovarian sex-cord stromal tumors, which are somewhat of an enigma. And these include the most common subtype granulosa cell tumors, as well as much less common Sertoli Leydig cell tumors that can be classified as either well, moderately, or poorly differentiated based on their histologic appearance. For granulosa cell tumors, they're, of course, very rare. The mean age is in the 50s, but there's an extremely wide age range. We see patients who are newborns or infants even, and we see women, of course, into their 80s and 90s. It's usually unilateral. It's usually confined to the ovary, so it's stage 1. It may produce estrogen in some cases, and there are a number of tumor markers that can be used to monitor it, including serum inhibin, anti-Mullerian hormone, and estradiol. And it's also associated with a somewhat increased risk of both endometrial and breast cancer. And we now know, based on recent evidence, that about 90% of granulosa cell tumors have a FOXL2 mutation. Unfortunately, this is not yet translated into better treatments, but we hope that that occurs in the near future. Sertoli-like cell tumors are also usually unilateral stage 1, but a much younger age group, generally the median age of 28 years. These tumors more commonly produce testosterone, so you may have a virilization as a presentation. They may produce also alpha-fetoprotein as a marker, and their biologic behavior really just depends on their differentiation and whether they contain any heterologous elements in the tumor. This tumor also, let me go back, sorry. This tumor, many of these tumors have a Dicer1 mutation, either germline or somatic. And again, like the FOXL2 and granulosa cell tumor, this is not yet translated into better targeted therapy. The standard surgery for these sex-cord stromal tumors is THBSO with surgical staging, but in young patients, fertility-sparing surgery is certainly possible. If patients have advanced stage disease, cytoreductive surgery is performed, although lymphadenectomy is not recommended because lymph node involvement is extremely rare. And of course, as I mentioned, endometrial cancer may occur in association, so you need to either remove the uterus or, if you're preserving fertility, do a endometrial biopsy. If patients develop recurrence, then secondary cytoreductive surgery is frequently recommended. In terms of the postoperative therapy for patients who have disease confined to the ovary, surgery alone is usually the treatment, with the exception of patients who have a poorly differentiated Sertoli-Leydig cell tumor where the recurrence risk is fairly high, and so chemotherapy is recommended. But there's really no consensus about the type of chemotherapy, and certainly when you're talking about ruptured stage 1 disease or metastatic disease, there's no consensus about whether chemotherapy should be recommended because these tumors are only modestly sensitive to chemotherapy. The most common regimens are platinum-based and either include paclitaxel carboplatin or the combination of bleomycin etoposide and cisplatin. And this is just one of the studies that calls into question the efficacy of cytotoxic chemotherapy as adjuvant postoperative treatment in women diagnosed with metastatic granulosa cell tumor. And there are a number of other studies that reach the same conclusion. Like low-grade serous carcinoma, we know that granulosa cell tumors may be responsive to hormonal therapies, and so there are a number of case reports with varying drugs. I don't know how well you can see this, but again, the aromatase inhibitors, tamoxifen, and a number of other hormonal agents may achieve a response in granulosa cell tumor. But we also know that in the recurrent setting, chemotherapy may be efficacious. In this study, it's a retrospective study from our institution, we found a 42% response rate in women treated with Taxol for recurrent granulosa cell tumor primarily. And a study just reported by the Gynecologic Oncology Group, NRG Oncology, found a 29% response rate in women treated with paclitaxel or Taxol for recurrent ovarian stromal tumors. So there is certainly a reasonable response rate in the recurrent setting. We know that Avastin or bevacizumab is active in this study that was completed in the last few years. The response rate to bevacizumab was 16% in women with recurrent sex-cord stromal tumors. And this is an ongoing study in women who have newly diagnosed metastatic sex-cord stromal tumors who are randomized to either paclitaxel carboplatin chemotherapy or bleomycin etoposide cisplatin. The accrual for this study has been very slow, and I think this study, unfortunately, may be at risk for closure by the National Cancer Institute, but we have appealed to them to keep this study open because this is a very rare tumor, and this trial will answer a very important question about whether either one of these regimens is superior to the other. And then finally, just a few words about malignant germ cell tumors. This has been one of the real success stories in gynecologic oncology, and that's simply because malignant germ cell tumors are very sensitive to cytotoxic chemotherapy. These are the various subtypes of malignant germ cell tumors that occur, dysgerminoma being the most common. And if these tumors, of course, as you already know, are rare. They occur principally in girls and young women. The average age for having one of these tumors is 16. They are relatively very aggressive, and that probably is responsible for their sensitivity to chemotherapy. But their incidence is only 1/10 that of the male counterpart, which is testicular cancer. You can see the signs and symptoms. The good part about this story is that these tumors are usually unilateral. They don't involve both ovaries, and they usually are confined to the ovaries. So they're usually stage 1 in contradistinction to epithelial ovarian cancers. Prior to the 1970s, most patients did not survive, but with the introduction of modern chemotherapy, and particularly cisplatin in the late 1970s, this whole area was transformed, and we now have very high cure rates in this rare tumor. Importantly, these tumors can express tumor markers, either alpha-fetoprotein or human chorionic gonadotropin, as you can see. Standard treatment then is surgery, which in many cases, if not most, would be fertility-sparing surgery, preserving the contralateral ovary and the uterus. And then in most cases, the treatment has been chemotherapy for 3 to 4 cycles with bleomycin, etoposide, cisplatin, although there have been some exceptions. And here you can see the cure rates, which in stage 1 and 2 approach 100%, a little bit less in stage 3 and 4, but even there, they are better than 75%. And the area of concentration in germ cell tumors now is to limit the extent of surgical staging. So, for instance, to try to avoid routine lymphadenectomy, which may lead to lymphedema, and also to reduce the toxicity of postoperative therapy, which may mean eliminating chemotherapy altogether in a high proportion of patients who have malignant ovarian germ cell tumors. So there's a study that was activated in May of this year. It's an international trial, just very briefly. Women who have, and this is all sites, so it's testicular, ovarian, as well as extragonadal germ cell tumors. Women who have disease confined to the ovary can be enrolled in this trial and undergo surveillance with no recommendation for postoperative chemotherapy. However, if they relapse during the monitoring period, of course, they would then be treated with chemotherapy. So the hope is that this will spare maybe 60 to 70% of girls and young women with these tumors from having chemotherapy. There's a second part of this trial for women who have stage 1C, 2, and 3 disease, who are randomized between the standard regimen of cisplatin, etoposide, cisplatin, etoposide, and bleomycin, with the substitution of carboplatin for cisplatin. And of course, carboplatin is generally much less toxic than cisplatin. So again, the overarching principle here is to reduce toxicity. And so this trial could be very practice-changing in allowing us to avoid chemotherapy altogether in a significant proportion of girls and young women with this tumor, or to give less toxic chemotherapy. And I don't have time to talk about all the late effects, which could include infertility, but fortunately, a very small proportion of young women or girls will have infertility related to postoperative chemotherapy, and this is a patient treated years ago for a ovarian dysgerminoma with surgery and chemotherapy and her family. So in conclusion, there are obviously multiple challenges that are associated with the study of rare ovarian cancer, particularly in terms of clinical trials. I think we've made considerable progress in some of these tumors, less so in others, as I've tried to illustrate a little bit. And a major challenge has been feasibility. So mucinous carcinoma, as I've tried to describe, is difficult because of the rarity, the extreme rarity, whereas it is feasible to conduct trials in clear cell carcinoma, low-grade serous carcinoma, and certainly in sex cord stromal tumors and malignant ovarian germ cell tumors. And I think, we need to continue to focus on improving outcomes for girls and women with rare ovarian cancers, and this can be done. There are a number of strategies that can be used in terms of networks, international trials, tumor registries, and using novel trial designs. So I will stop there, and I'd like to thank everyone for your attention, and I'll turn it over to Sarah for questions.
Great. Wonderful. Thank you so much, Dr. Gershenson. That was excellent. So much good information. And someone sent in a question. Yes, this is being recorded. So I know there's a lot of information shared. So this is all being recorded. It'll be posted on the OCRFA website sometime tomorrow. And we'll send out an email to everybody and let you know when that's up. So you'll be able to go back and hear the recording and see all the slides. Okay, so we do have some time for questions. We've gotten a bunch in. Dr. Gershenson, I'm wondering if you can talk a little bit. I mean, you kind of touched on this. Some of the trials you mentioned a few that were eventually closed because of problems with accrual. And obviously that's very, upsetting to hear. So I'm wondering if you could talk a little bit more about clinical trials, how you think we can perhaps overcome some of these barriers to low trial accrual, and what might you say to a patient with a more rare ovarian cancer who's thinking about a clinical trial?
Thank you. Well, excellent question. I think, if there is a clinical trial available, and one of the problems is there are not nearly enough trials available. It also takes a long time to develop a trial. And the average time can be a year or sometimes even 2 years in many instances. So it's a long process. But if there is a trial available, we certainly encourage women to at least hear about the trial, have informed consent, look at the pros and cons, and make their own personal decision about it. Yes, it is very frustrating, disappointing to everyone when you have a trial that is activated and not able to be completed because of slow accrual. And, because we only started to conduct these types of trials, as I mentioned, in 2007, 2008, when we got some of these trials started, it was a learning process. And we, for instance, had no idea that we would not be able to conduct a randomized trial for mucinous carcinoma. So now I think we have to go back to the drawing board using that as an example and look at one strategy is to look at smaller trials, so phase 2 trials instead of randomized trials. Randomized trials are always the ideal, but they cannot always be conducted because of the feasibility issue. So I think we have to be smarter, and I think we have learned a lot of lessons in the last decade. Also, I think we've undersold the importance of some of the retrospective data or data from tumor registries where in certain tumors we'll really never be able to conduct effective clinical trials. So I think we just have to be very smart and flexible and try to use the best strategies we can. but I think we have learned a lot of lessons in the last several years.
Okay, great, thank you. So, okay, we've had some questions, a lot of questions about clear cell and low grade. So here's the first question about low grade. Can you tell us more about the role of Avastin as maintenance therapy in low grade ovarian cancer? Are there any statistics on how effective it is in delaying recurrence?
Well, so in ovarian cancer in general, epithelial ovarian cancers, there have been, as I think probably many on this webinar know, there have been a number of clinical trials both in the U.S. and Europe that have shown advantages of bevacizumab or Avastin maintenance therapy. The advantages have been in the area of progression-free survival, improvement of progression-free survival on average in the 4 to 6 month range. They have not really shown a better overall survival, but they definitely have shown some advantages in epithelial ovarian cancer in general. Certainly in some of those trials there have been women who have low-grade serous carcinoma, but there really haven't been any detailed analyses of those women, or there just haven't been enough to really make any good sense of the analyses. So we really don't know in low-grade serous carcinoma, when we're talking about using it as maintenance after primary chemotherapy and in conjunction with primary chemotherapy, whether or not it's really going to be effective. The data I presented were mainly for recurrent low-grade serous carcinoma, where we know the response rate, as I mentioned, could be 40 to 50%. So I think the question is unanswered in low-grade serous specifically in terms of the benefits of maintenance therapy after primary treatment. But again, in ovarian cancer in general, it's shown advantages in progression-free survival, but not overall survival.
Okay, thank you. So one specific question again about low grade. Regarding the low-grade serous trial, RT1713, prospective participants are often uncomfortable with randomization. In this trial, 2/3 of the patients will be randomized 2 times. Is there a reason why the initial randomization is not straight into the 3 arms?
Great question. We have grappled with this. We've worked with 2 outstanding statisticians, one in the UK and one in the US. We've gone back and forth on this question. I think, they have decided that it's going to be better for statistical reasons to have 2 randomizations, but we did definitely very seriously consider 1. Now, this study has not been approved yet. It will be going to the Gynecologic Cancer Steering Committee later this month to see if we can obtain approval. Again, if we do, it will be an international trial. But I totally understand the issue of randomization, particularly with this trial, because of the various treatments that are included in the randomization. But we think this is going to be the only way to really answer the question about whether hormonal maintenance therapy or hormonal therapy as a substitute for chemotherapy is going to be a better treatment and result in a better outcome. So this potentially will be a practice-changing trial, but the statisticians in their wisdom, at least at this point, have considered both options and decided for statistical reasons it was better to to design it as 2 randomizations in one of the arms.
Okay. Lots of good questions here. Let's see. A question came in, could immunotherapy be effective for low-grade serous carcinoma? I guess so. I'd be interested in hearing your thoughts on, is there anything in development with immunotherapy for any of these cancers?
Well, for most of the trials that I'm familiar with, and we just started an immunotherapy trial here recently for patients who have recurrent ovarian cancer in general, again, not specific to cell type. It could include patients who have low-grade serous carcinoma, I think at this point in time, we really do not know whether immunotherapy is going to be effective or not, I think in ovarian cancer in general, and specifically whether it will be effective in low-grade serous. I think the most excitement right now is with clear cell carcinoma, just because of some of these case reports with women who had very excellent responses. But on the other hand, we don't know that it won't be effective in low-grade serous. It's just too early to tell. We are, in our group, conducting some preclinical studies with immune checkpoint inhibitors in cell lines of low-grade serous carcinoma. And we had a discussion today where we're finding there's a protein that may be produced by the low-grade serous carcinoma that may block the effectiveness of immune checkpoint inhibitor therapy, so that if we can really confirm that this protein is real and it is blocking T-cell activation or proliferation, we may be able to develop an antibody against that protein that could be used in combination with immunotherapy. So I think, again, there's a lot of exciting work going on, but it's much too early to tell whether immunotherapy will be effective in low-grade serous carcinoma. I think we'll know a lot more in a couple of years.
Mm-hmm. Okay. Some questions about clear cell. This is a more general question. Is there a benefit to a meeting with an oncologist who specializes in clear cell, a trip or a phone consult, when the patient has NED after chemo, so the patient can be optimally prepared in the event that cancer does recur?
Yeah, I mean, there's a question about, who are experts in clear cell. I'm not sure if there's anybody who's an expert in clear cell, but yes, we would always encourage second opinions. Mm-hmm. To see someone who maybe has an interest in clear cell specifically, or who has been involved in clinical trials, because as I've tried to show, even though some of the results are disappointing at this point, there is a lot of hope, and there are investigators, certainly in the U.S., who are very much interested in improving therapies for clear cell carcinoma. So yes, I would always encourage a second opinion.
Okay. We have two questions about, let's see how to word this. So one person says, what is the relationship between clear cell cancers and their frequency in Japan? And related, another person was wondering if the clear cell ovarian cancer that's seen in Japan, would it be basically biologically equivalent to women in other parts of the world? So can it be generalized to others?
Excellent question. So clear cell carcinoma is much more common in Asia than it is in the U.S. We don't understand why. A number of epidemiologic factors have been studied, including diet, but we don't have a good explanation at this point. The other part of the question is, are they biologically different? Is the molecular biology of clear cell carcinoma in Japan, for instance, different than it is in the U.S.? And I don't think we've answered that question yet, but it is under study, and I think hopefully within the next few years we will have a solid answer to that. I think a lot of experts feel that it may be different biologically in some way, but I don't think we really know the answer, nor do we have enough information to really use it in terms of triaging various therapies at this point. So a great question, but I would say stay tuned.
Mm-hmm. Okay. You mentioned that chemo, carboplatin and Taxol is somewhat controversial for clear cell stage 1. Why is that, is the question?
Well, again, there have been no prospective trials to date, although there are some trials that are, I think, in development. That is because, in the recurrent setting, clear cell carcinoma is not as sensitive to chemotherapy as we would like it to be. And so there's a thinking that if it's confined to the ovary, stage 1A, surgery may be really the main treatment, and you don't need chemotherapy. And there have been some retrospective studies or case reports that have, described women who had surgery alone and had a very good outcome. They were cured with surgery alone with stage 1A clear cell carcinoma. So that there's this lingering question that has not yet been adequately studied. I think many of us at this point, without further evidence, are very hesitant not to recommend chemotherapy, because if it is, if it is effective, then we certainly wouldn't want to withhold that. So I think the principle right now is, since we don't have the complete answer, most of us would rather overtreat than undertreat and have a recurrence that might have been prevented. So again, we don't have the true answer, but there are experts around the world that are questioning whether chemotherapy in stage 1A clear cell is really necessary.
Mm-hmm. Okay, thank you. All right, just a few more minutes here. Someone asked a question about Zejula, the newly approved PARP inhibitor. And, in the ovarian cancer community, we're all aware of the excitement around these new drugs. Could you comment a little bit on, they're not approved for these rare types, but is there any research, anything that any thoughts on the future with PARP inhibitors for these cancers?
Yes. So a couple things. So of the rare cancers I discussed, probably the one that comes to mind that certainly could be associated with the BRCA1 or 2 mutation is clear cell carcinoma. So if that were the case, then PARP inhibitors certainly would be promising in the treatment of a clear cell carcinoma with a BRCA mutation. For low-grade serous, the best studies that have been conducted would suggest that about 6% of women who have a low-grade serous carcinoma have a BRCA1 or 2 mutation. So again, that could be a useful information that could lead to effective treatment with the PARP inhibitor. And then the last thing I would mention is that I tried to show is that in preclinical laboratory investigations, we and some other groups have shown that combining a PARP inhibitor with a MEK inhibitor in low-grade serous carcinoma may be more effective than giving a MEK inhibitor by itself. So there's, I think, mounting interest in that area as well. So there are some potential usefulness for PARP inhibitors in clear cell and maybe low grade. I don't think we know much of anything about any of the other cell types that I discussed.
Okay, thank you. Let's see here. There's a question about germline mutations. Do you know, is there anything known about germline mutations that might be significant for low-grade serous ovarian cancer?
Well, as I mentioned, the main germline mutation that's been described is
BRCA, yeah.
the BRCA and 6%. Right. We don't know of any other germline mutations that occur in low-grade serous carcinoma other than that small frequency of BRCA at this point. But, lots of genomic studies that are ongoing, and hopefully at some point somebody will discover other germline mutations or other germline aberrations that occur, but at this point, no.
Do you consider borderline ovarian tumors to be cancer?
No. I don't. They are not invasive cancers, and usually, most of the time they're stage 1, and the cure rate is approaching 100%. It's like 99.1%. However, when somebody has a borderline tumor and has the association of peritoneal implants with the borderline tumor, it's still not an invasive cancer, but that generally, we now know from the last decade of research that there is a risk, of lifetime risk of subsequently developing invasive cancer, and that could be 2 years later and it could be 30 years later. So, but no, strictly speaking, we do not consider borderline tumors as cancer.
Okay, well, I think we're going to have to end it there. Our hour is up. So thank you again to Dr. Gershenson for spending time with us today, and I want to thank everybody for calling in. Again, this is being recorded, and someone asked a question. Yes, the slides will be available as well. Please take a minute to fill out the survey that will pop up on your screen at the end of the event, because your feedback is always really useful to us. We're always looking for ideas for new future webinar topics. And I guess that's it. So if more information about OCRFA, you can always visit our website, www.ocrfa.org. So thank you all, and thanks again, Dr. Gershenson, and have a wonderful evening.
Thank you, Sarah.
Thank you.
Everyone.